Hello, friends. Welcome to Veritas Podcast. We have another episode. We have a special guest today. We have Dr. William Andrew Wells. He's an ENT specialist, and he's an allergy specialist too. And we're going to talk about allergies today. So welcome to our podcast.
Thank you, Lachin. It's great to be here.
Sure. So your background, you're an ENT doctor?
ENT? Yeah, I've been in practice for 26 years. The bulk of my career was in Augusta. Started a large group there. We started with just a couple of doctors and then grew it to 14 doctors. But a little over a year ago, we decided to kind of expand and do a new step. I had children that had moved to Charlotte and Charleston, and we've been coming to the Lake Murray area for years. We loved it. And so it was kind of an easy transition to be closer to them, closer to the grandkids. And it was kind of fun to start a new chapter. And so we opened Columbia Breathe Free just here on Sunset Boulevard. And we've been open almost a year now.
Interesting. So you're on Sunset Boulevard. What's your exact address?
4711 Sunset Boulevard, right directly across from the Goodwill.
So you're specialized in allergies, sinus problems. What's your most bread and butter? What cases do you see?
Sinus and allergy mainly. We treat all types of ENT issues, but we're highly focused and specialized in sinus and allergy, nose and rhinology symptoms, things that affect breathing through the nose, sinus infections, allergies that affect, drippy, sneezy, runny nose. And those things naturally impact our sleep. So we take care of a lot of, I'm a sleep specialist. We take care of a lot of issues with snoring, sleep apnea, things like that.
So you set up CPAP machines?
Yes.
Okay, perfect. Good to know. So sleep apnea, I don't know that actually. I usually send you patients for sinuses and allergies. So I don't know.
We appreciate that.
Sleep apnea too. That's good to know. So I have a lot of patients have sleep apnea problems. So
very common, very pervasive problem for folks.
So living in South Carolina, we have huge allergy, pollen issues here, and a lot of people have allergies, especially people moving from different states to this area. Mm-hmm. They complain about allergies. So what are allergies? What's in general terms?
That's a good place to start. So allergies are propagated by our immune system when it overreacts to harmless, normal substances in our environment. So we typically think of, pollens and dust mites and mold and things like that. Those are just normal parts of our environment. But when people develop allergies, their immune system overreacts when they're exposed to those substances. The immune system generates these proteins called immunoglobulins, and one in particular, immunoglobulin E, is the main one that will trigger a lot of release of chemicals in our body that bring about our classic allergy symptoms, whether they're itchy, watery eyes and drainage, or the congestion and drainage in the nose. Those are all triggered by that immunoglobulin E triggering that release wherever it happens to be in the body.
And how you test for it? Like if somebody comes to you, say, I'm allergic, I have runny nose, I have itchy skin, I have skin rash, how you know what they're allergic to? What's the next step?
That is a very important part of the process. So there really are two ways to test. One way is definitely superior to the other. There's skin testing, and then there is blood tests that you can do. The skin tests are by far more accurate. There are some folks, if they have a skin condition, we call it dermatographia, you can't really do a skin test on those folks. There are also some people that for one reason or other can't come off certain medicines like beta blockers. You can't do a good allergy test on those folks. So there are some instances where we need to get a blood test. The blood test actually measures that immunoglobulin we talked about, the IgE. It measures that level in the blood. But it's not as sensitive as a skin test. But 99% of people can get a simple skin test. We call it a prick test. It's a simple little multi-pronged device that we do just on the upper part of one arm. And that, along with a few other spots that we can test, we can get a very accurate test. We don't have to go all over both arms and the back like they used to do. So the test is much more streamlined now. It's very easy to do, very quick. It's so simple that we can test kids 5 or 6 years old on up.
So 5 and 6. So that's a pretty young age to start allergy. It's a good time to. How many allergens do you test at a time for a skin test?
Yeah, we probably test anywhere between 45 and 60 allergens, depending on that patient's history and some of their symptoms.
45. And you mentioned the beta blockers. Why you cannot test them on beta blockers?
Yeah, the beta blocker, it doesn't impact the test itself. The reason that we can't have a patient on a beta blocker is because if they, in a rare instance, if a patient has a severe reaction to the test or their allergy shot, let's say, and this is very rare, but if they would have an anaphylactic reaction where they can get swelling of their throat, their airway, they can get constriction of their airways and cough, and it's a serious thing. The medications that we treat that with, they act at a place called a beta receptor. So if they're on a beta blocker, then those rescue medications that we use won't be as effective. And so that's a situation we need to avoid.
So do you take them off the medication for a while before you do the testing, or you cannot do absolutely?
Yeah, we can take them off that medication for a week. We're good to do the test.
Okay. And how do you treat them? So, okay, you do the testing and you identify, okay, I'm allergic to certain plants, or I'm allergic to dust mite, or I'm allergic to cats and dogs. What's the next step? What can you do? Okay, you identify the problem. What's the solution?
Yeah, what we do is we'll test for several different categories of things. We'll test for the outdoor pollens. So we have trees, we have grasses, we have the weeds like ragweed that people normally think of. We'll test for molds. We'll also test for insects. Those can be indoor or outdoor. Some indoor things that we test for are dust mites. And then certainly we test for animals. Those can be in or out. It will also test for, we can do some food testing as well. Okay. So when we do the test, we check for, on the trees, there can be a long list of trees. You've got your maple, your oak, your elm, your birch, bayberry. You've got your lobby pine, sycamore. I mean, trees can be a very long list. We kind of narrow it down to about 8 or 10 that are primary in this region. The grasses are typically your Johnson, your fescue, your fennel, your rye, your Bermuda. Those will cover most of them. And then the weeds are certainly, people always talk about ragweed or hay fever. Those will be your ragweed, your dock sorrel, your nettle, your mugwort. Those are kind of your top ones. So the trees, those come out in one of the reasons you mentioned is as South Carolina and Georgia have such a long pollen season. And so it's a very high concentration of allergy patients in these regions. Well, the reason is the trees start blooming in late January, and they'll last all the way until late summer. And then you have your grasses. They come on the scene in mid-spring, like March, and they'll last until early fall. Wow. And then you have the weeds. Those come on midsummer, and they're here until there's a freeze. So the patients in this area probably only get a break from allergies December, January. That's about it. Couple months. So it's a very long allergy season. And so we test for a lot of things because there's a lot of things that can be, patients can be sensitive to. Try to narrow it down based on their history. But insects, some of the main ones, are certainly mosquitoes, but cockroaches are one of the big ones in this area. Ants people can be very sensitive to ants. And then, we also talk about stinging insects. If people have a real strong reaction to a bee sting, then that's part of the process. But once we test them for all those things and they have a certain reaction that we consider positive. Then we put together a treatment plan for them. There's two options for treating allergies. Either what we call sublingual therapy, which are drops under the tongue, or we call subcutaneous immunotherapy, essentially allergy shots. And based on their pattern of sensitivity, we put a mixture together, and the allergy drops and the shots are both very effective. They've got
so they're both equally effective, or one is better than the other one?
They're really both equally effective. Okay. There's some debate about that. There is some schools of thought that the allergy shots are a little more effective. You can put more into an allergy shot mixture, but as long as patients' sensitivities aren't too widespread, you can get most of what they need in the drops. And so for most patients, they're pretty equal. Now, the difference between the two are that the drops, you have to use them every day, whereas a shot is just once a week. Okay. You can do the drops at home. They're great for kids or patients that don't like needles. Okay. And so that's kind of the positives. The negatives are most insurance don't cover the drops. Okay. So that can be a big negative for a lot of people. When you talk about
doing in practice, both of them, or
we do both.
You do both of them.
So the shots, they're given once a week. They're usually given in the office, but for a lot of patients that meet a few criteria, they can do them at home, as long as they have somebody that can give them the shot, or if they want to do it themselves. So that's a real game changer if patients can do it at home. A lot more flexible that way. The shots are covered by insurance, so that's no problem there. And so those are the two options. The time that we treat patients, you're looking at a couple of years to get through the process and get good control of your allergy symptoms.
So it's a long-term tool. How often you go get the allergy shots? I know they have frequency changes as you progress.
Yeah, we usually start out once or twice a week, and then we escalate up, and then we quickly get into just once a week. And we'll hold that for probably 3 to 6 months. And once you get to the strongest concentration during that time, we're increasing it slowly each time. Then we get on what we call maintenance therapy, where you're just getting the once a week shot. And during that time, that's when your immune system is changing and what we call desensitizing that immune system to all those things that previously they were overreacting to. So it's done with blocking antibodies that block those IgE molecules. But essentially what's happening is we are desensitizing your immune system so that it stops reacting when you're exposed to those normal, common things in the environment.
Do you check the blood levels while you're doing the shots? Like, do you check for IgE levels or anything like that? Or?
Yeah, the IgE levels are interesting. They're not very. There's not a good correlation between IgE level and how allergic someone is, or whether they're allergic to this particular substance or allergen versus another. So we typically don't measure IgE levels. We really titrate someone's treatment to their symptoms. And when their symptoms are getting better, which normally most people will start seeing significant improvements in just a month or two.
I mean, allergies is a big problem in a sense because it doesn't just stay with allergies. People have allergies for a while, and then because of all the congestion, they turn to bacterial infection.
Exactly.
Because, you are congested, you already have a lot of mucus and phlegm production. That bacteria loves that. So it progresses into bacterial infection, which needs antibiotics. Because usually it's the same story. I see like 40 times a day in the urgent care. I have allergies and I had this, but this one is not going away. Now it's like green stuff coming out. And now I need some antibiotic, maybe steroids along with it. So how about the myth about the local honey? Does it work or is it just a myth?
No, I think there is benefit to local honey. It's very anti-inflammatory. It has a calming effect on the immune system. So it's actually there is some truth to that concept about local honey helping with allergies. It does have a beneficial effect. Now, will it change your immune system and knock out all of your allergies? No.
Do you treat peanut allergies if somebody's allergic to peanuts? Or
There are that's a highly specialized allergy treatment process. So we do not do that. We refer that to a specialty center, referral center that does oral challenge with peanuts. And you're really not going to have someone that literally becomes completely unsensitized to peanut. That treatment process really, the purpose of that is if someone has a life-threatening allergy to peanut, where if they get the peanut oil on their skin, they can go into anaphylaxis. Those folks, that treatment process is to lower their threshold for anaphylaxis so that if they're exposed to peanut, they're still not going to eat peanuts or be around it. But if they are, they have a less severe reaction, which that's a big benefit.
Yeah, I mean, I wonder if you get like anaphylactic reaction to a bee sting or a peanut, or some people almost die because of it.
They can do, and it's those same specialists that we'll refer to for if someone has a stinging insect. They call them vespids, but the stinging insect allergies, same way, you can desensitize to bee stings, and actually a little bit more effectively than the peanut even.
So you've been practicing in Augusta and then you came here. Is there any difference in the allergy profiles between Augusta, Georgia or here, or is it about the same?
It's really about the same.
Okay.
Jen. Yeah, it's very, very similar. I haven't seen much difference at all between the two.
What's the number one thing people are allergic to in the panel?
Oh, probably, that's a hard one to say because, but I would say that probably the number one thing is grasses. Grasses and trees.
And then you also treat sinus infections.
We sure do.
Yeah, we get that quite a bit in the urgent care. I send you a lot of patients for sinuses, and I have some patients have sinuses maybe 4 or 5 times a year, and I'm just, at what time they should come to your office? Like what kind of frequency they should have before they should seek more higher level of care with your office?
Yeah, that's a very helpful thing for us to talk about. So first of all, allergies and sinusitis, they go hand in hand. The allergies, they trigger inflammation throughout our whole respiratory tract, from the top of the sinus to the bottom of the lungs. And so they can impact lots of different parts of our system. They can hit the eyes. People can have those itchy, watery eyes. I've seen it a lot more in the spring this year. It's normally a lot worse in the fall with ragweed, but this spring, a lot of people have had allergic conjunctivitis with that. It certainly affects our nose and sinuses, and that's what you're alluding to there. I mean, we get a lot of congestion. We have a lot of drainage, a lot of itching, sneezing, and that whole inflammatory process leads to blocking up those sinus openings. And when the sinuses get blocked, then they get backed up, and it's easy for bacteria to get started, and you get a sinus infection. So what we usually say is if you've struggled with sinus infections or a lot of sinus inflammation, pressure and congestion and thick drainage, if you've had that for several months and you've had an antibiotic or two and they either didn't help or they helped, but then those symptoms just kind of came right back within a month or two, it's time to come see us. And what we'll do is on your first visit, we'll take a good history. We'll find out what's been triggering you and what treatments you've had. We'll get a simple sinus picture, and that'll tell us exactly what we're dealing with.
It's an X-ray or CT scan?
It's a simple CT scan. That's designed just for the sinuses. It's a chair scanner, we call it. So people just sit there. It just rotates very simply around their head. We can do kids 3 years old and up. It's so simple.
I had it done. It was pretty easy.
There we go.
You got it done?
Yeah, I had the surgery.
Oh, nice.
Yeah.
2011.
Did it work out?
Changed my life. I was just telling Dr. Wells.
Wow,
Yeah.
you had it.
Tell us about what the other options are for surgery.
So how can you treat it? Say, okay, you do CT scan. I would say, okay, I have my right maxillary sinus is all blocked out, congested, full. What you do next?
There we go. So once a patient, has a diagnosis of chronic sinusitis, clearly you can see on the scan if their sinus is blocked and if they've got a lot of inflammation and mucus buildup in there, then what we can do now is so much better than what Scott had to deal with. The traditional sinus surgery, which is still done every day, in here in South Carolina and Georgia.
Pretty scary, too. I saw it on the. It looks. I saw the YouTube videos on that one. I've been into a couple of them personally in the OR, and they pack it with this much gauze. And it's scary looking. It's bloody.
Long strips of gauze. So let me tell you about what we do and how we compare, and Scott can validate this. So what we found is just like they do angioplasty for coronary artery blockage, has just totally supplanted the need in many cases than an open heart surgery. So many patients can be cleared up that way. It's so much simpler and safer. And it's very analogous to that. What we do is we work on the premise that the doorway in and out of the sinus is the key to the sinus being healthy and staying out of trouble. We all know that's true. So if we can get that back open, then the patient is well on their way to clearing up. So rather than cutting and removing tissue like the standard approach, we slide in a balloon catheter. It's very simple and safe to do. We spray the nose with some numbing and decongestant spray. We slide little cotton strips into those sinus areas that have that same solution on them. And that allows us to very comfortably slide in a little balloon catheter. It's only a couple millimeters big. It expands the balloon, which remodels and opens that sinus doorway. It only expands to 6 millimeters. So we're not talking about these large balloons. But for a sinus opening, that's plenty big. So we slide it into each little sinus that's blocked. It's only in there for 5 seconds. You deflate and remove it. Patients don't go home with a balloon in their sinus. And that will get their sinuses back open. The procedure takes about 30 minutes. There's hardly any bleeding at all. There's no packing in the patient's nose when they go home.
Is this an OR procedure or in office?
It's done in the office with just light sedation. And the great thing, so that's resonating with Scott, who had all that packing that's very uncomfortable. You can't breathe, very painful to have it pulled out. The recovery time, because we're doing it with just a light sedation in the office instead of general anesthesia, because we're not having any bleeding, because there's no packing, our patients are back to work and school in 2 or 3 days versus 1 to 2 weeks. I think you were.
I was out of work for 8 days.
8 days.
That's, what's the youngest age you can do?
I've done 8 years old and up in the office.
8 years, wow. And this can be, and how often do you need to, is it just one-time deal or do you have to come back for multiple times?
Yeah, it's really, it's really an approach of one and done because as opposed to traditional sinus surgery where you introduce a lot of tissue damage and you trigger a lot of scarring, which then now you're fighting that scarring because it wants to close that opening down by a scar. With using the balloon, we're preserving all that tissue, all that mucosa, that lining of the doorway in and out of the sinus. We're preserving that. We're just gently dilating it. So we don't trigger the scarring. So that opening stays and heals nice and open. So we have much longer results, and we usually don't have to do anything again. If one sinus, for some reason, gives us trouble down the road, it's very easy just to go back and just gently open it back up again, clears them right up. But that is not the norm. One and done is usually the approach.
And it's good for people, like they don't have to be staying out of work. I mean, they go home. They can do it over a Friday and then go home.
Yeah.
Same day.
Yep.
That's going to be a lot of people. And what is the insurance coverage? Everybody, or just privates and Medicare? Or
Medicare, Medicaid, the commercial insurance all covers the balloon sinus dilation approach. They cover the in-office procedure. We give 2 options for sedation. We do oral sedation, which we give you some pills to take, both at home before you come in, and then once you get to the office, and you're nice and sleepy and relaxed. Some patients prefer kind of not being aware of anything at all, and so we can do a simple little IV sedation, like they do at the dentist for wisdom teeth. We do that so patients are just in a lighter sedation where they're just sleepy and unaware of anything. And then we do the procedure, and they do fantastic. All those things are covered by insurance. So it's a very good, easy thing to be able to offer patients.
And you need to bring a driver, I assume.
You do need to have a driver with you. You're usually in the office an hour to an hour and a half just for the prepping part. The procedure itself is usually 30 minutes, give or take.
Wow. It can be much better than what Scott went through. Yeah. It's a big procedure.
Can I have the balloons after my surgery?
Yeah, after surgery.
I've treated a lot of folks because of that scarring problem. A lot of patients that have had the traditional sinus surgery, they've had some of their sinuses will kind of scar closed. And then down the road, they're like, I'm starting to have this trouble again. And they'll come in and we'll do get a scan. And I'll say, well, look, these sinuses, they still look like they're doing okay, but there's a couple here that we really just need to get to open back up. And so we do it real easy in the office with the balloon. And they're like, I can't believe that was night and day different. I'm very thankful to have the balloon now, but they clears them right up. It's kind of great because what we can do when we're in the office is not only get the plumbing open, get that sinus doorway open, but there's also the lining of the sinus has to be healthy. And so there can be a lot of problems with that. Well, because we get that sinus open, we're able to flush out a lot of mucus that's in there right there at that time.
So you inject water and you kind of...
That's right. You circulate
flush.
Water through there, we suction it right back out. And then we're actually able to put this medicated gel inside the sinus.
Wow.
And this gel is very cool. It's most gels, when you warm up to body temperature, they get real thin and fluid and they just run right out. And then when they're cold, they're real thick. Well, this gel was developed to be very thin and fluid when it's cold, but when you slide it into the sinus and it warms up to body temperature, it gets real thick. And so it stays in the sinus and won't run out. So it stays in there for several weeks, and it carries, we put antibiotics and steroids in it. And so it just bathes the sinus in this medication and really helps it to heal up.
Is there a selection criteria like your insurance company will say, oh, you need to fail treatment with antibiotics to come qualify for this procedure, or they can come to you directly?
Yeah, they can come to us directly. Some insurances have no specific requirements. Basically, what we say is, you should have symptoms for, more than 12 weeks to be considered chronic sinusitis. Most people have had symptoms a long time, whether it's months or years. They've been treating it a long time. And then, have you had several antibiotics, over the course of time to try to treat things? Some insurances require, a couple different antibiotics. Some people require like 21 days of antibiotics, over the ensuing months that you've had symptoms. So whatever those are, we'll make sure that you've had them, or if you need more, we'll give those to you. And then we see how you do. If you clear up, great. If you're still having trouble, we've got an easy solution.
And I see that a lot of sinuses getting worse when people fly. It's kind of like ear infection, like air pressure makes a difference for sinuses.
Yeah. There are two things that really give patients fits when they fly. Their sinuses and then their ears. So the ears are connected to the nose and sinus through the eustachian tube. And that's the job of the eustachian tube. Just like the doorway into the sinus, its job is to let that sinus or that ear drain and to let air circulate in and out of there. If it can't do that, then that ear or that sinus gets in trouble. So when they fly, there's a lot of pressure, and that air needs to move in or out depending on whether you're going up in the plane or whether you're descending to land. If that air can't get in or out, then you've got that pressure trapped. That air is trapped in the sinus or trapped in the ear, and those patients can be really miserable. And a lot of patients have experienced that to some degree or another. They know how much it hurts when they're descending, that pressure goes up. And if their ears don't equilibrate well, it can be very painful. So if simply dilating that eustachian tube, which is part of what we do in the office, just like we dilate the sinus, they could fly the next day. I had a patient that he was a grandfather, and he and his wife, their grandchildren lived in California, still do. And he came to see me because he said, my wife likes to go out every 3 months to see the grandkids. And he said, I only go once a year because it is such a painful experience for me. And he said, is there anything you can do? And I said, well, sure. We just dilate your sinuses, because he had a few blocked sinuses. And I said, but we're going to dilate your eustachian tubes. And this was like on a Wednesday. And he said, well, we're leaving Friday. I said, let's do it tomorrow. He comes back tomorrow, just took the pills, oral sedation, dilated his sinus, dilated his ears. Next day, he called me from California. He said, you've changed my life. He said, my ears didn't bother me one bit. I was so happy when I got here. He said, I can come as often as I want. And that's just a very encouraging story. We get all kinds of stories from people that how we've changed their life.
I mean, maybe I should benefit from it because, I tried to get my diver's license. And one of the reasons I couldn't get it is because, they said do not dive when you have allergies and you have sinus issues or you're congested. I couldn't equalize. Like my ears were hurt so much. So my eustachian tubes are shut. And I did all the techniques blowing against the pressure and I just couldn't equalize. So my sinus, especially on one side, I have eustachian tubes.
We can get you cleared right up.
Yeah, I should maybe come by.
I do a lot of divers. A lot of people from Florida will come up, but treat a lot of airline personnel that have trouble for one reason or another, whether it's airline attendant or the pilots. But then the divers come. I had a couple that they just retired. They love to go scuba diving. That was going to be their retirement. To go and the guy had terrible frontal sinus pressure, but he also had trouble with one of his ears. And so we got them dilated and he sent me a postcard from, I think Bonaire or one of those, Caribbean islands. And he said, I'm the happiest guy on the island. He said, I can scuba dive and do everything I want to do.
You should bought you a first class ticket.
That would be good. I try to say, hey, you need your personal physician to come with you just to make sure everything's good. Nobody's taken me up on that yet.
Yeah, I mean, they should. You change their lives. How about, let's change the topic to do it. We talk about allergies, we talk about sinuses. So the most common thing is sleep apnea. You deal with a lot of sleep apnea.
A lot of sleep apnea.
So what's your typical sleep apnea patient? What's the demographic? Is it mostly man, female, certain age, certain body weights? And
yeah, there's a stereotypic, stocky or heavy set male that, kind of that offensive lineman, thick neck kind of thing. But you'd be surprised. We have a lot of ladies that have issues with snoring or sleep apnea. It's not always proportional to the weight. I've had some very thin, lean people that because of the position of their chin and the base of their tongue and the length of their palate, you can have folks that you may not look at and say, oh, they don't have sleep apnea. I'm sure they don't have snoring, that can have severe problems. So if you took 10 people that were more lean and maybe thin, and those who were more stocky, overweight, if you will, or obese, you're going to have a higher percentage in that larger population. But it's not always what you see is what you get. So when someone comes in, tells them they have trouble, regardless of what their body habitus is, we're pretty keyed into, tell me what's happening. What does your bed partner tell you is happening? Because whatever they say, that's what's going on.
That's usually the one brings the patient to them. Their wife or husband is like, man, I'm tired of this. Let's solve a problem.
Yeah, I can't sleep with them. I'm scared for them. I can't sleep. And so you're right. It's their bed partner that usually is the one that is pushing them to come in. And so what we'll do is we'll simply set them up with a home sleep study. Very easy to do. I like it better because it's more, it's mimicking, what they're experiencing at home when they're in their own bed, their own circumstances.
Is it one night?
One night.
Okay.
One night. Every once in a while, we have to do a second if we didn't get good data, but it's not very often. The insurance companies, in a lot of cases, are requiring an in-home sleep study before they'll approve one in the lab anyway. Okay. But the home sleep tests have have really developed, and they give us a lot more information than they used to. And so a lot of times we're able to make a diagnosis and base treatment on that and not even have to get the more complicated sleep test.
The fun thing is I did not in home, in office, sleep study myself, and I was awake the whole time. I mean, I couldn't fall asleep, like 2 or 3 people staring at you. It was not my bed. I felt uncomfortable.
Yes.
I just and then they didn't get good data. I mean, I slept maybe 2 hours all night. And I was
not representative of all. And that's a very common story that I hear. People are just, it's like trying to sleep in a hotel room with somebody sitting right outside a window door, and
creepy.
So very creepy. So this is a much better way to go. We can get them set up on a home sleep test right away, see what they got. What we do when we treat, whether it's snoring or even sleep apnea, is that there are 3 levels of airflow impairment. Okay. So there's the nasal airflow. There's level 2. It's when you open your mouth and you look back and you can see where your tonsils are and your soft palate and your uvula hanging down. That's kind of level 2. And then level 3, a little bit more complicated to assess. It's really behind the base of the tongue, kind of back where your epiglottis is and the base of your tongue. And so what we do is we assess their airway very similarly to how we assess someone's airway when they come in with nose and sinus trouble. We just spray a little medicine, doesn't sting or they don't even feel it. It's decongestant and some numbing medicine, and we can look inside their nose real well with this little teeny camera. If they've got a sleep issue, whether it's snoring or sleep apnea, we've got a little flexible spaghetti type camera that just at the back of the nose, we can peek over the edge and we can see their airway from there very easily. So patients don't gag, they don't feel it in their throat, very easy to do. And so we'll look at their airway that way. But what we do is that the research has shown that the very first thing that gives you a huge benefit to your sleeping, your snoring, or your sleep apnea is to optimize the airflow through the nose. And I think Scott said after he had the sinus, a lot of times they'll do a few other things to help your airflow through your nose.
Yeah, he took my adenoids out and then removed a whole bunch of polyps.
Okay.
And I went from definitely having apnea without being diagnosed to a silent sleeper. My voice changed, so much happened. Yeah. I just sounded like this all the time.
Yep.
Before.
Can you have sleep apnea without snoring?
You can.
So what are the other symptoms? Like somebody comes to you, like,
well,
if you should look out for?
If they're not snoring, actually, it's a little more concerning because it means that if their bed partner says, well, they may not be making noise, but they'll not make a noise and then they'll make a big noise. So there'll be no airflow at all, and then finally the central part of the brain kicks in to says, you've got to wake up and breathe. They'll be, and then there won't be any sound for a while. So, if someone's breathing smooth and they're quiet, then they're not going to have sleep apnea. So that's the situation where they may not be, you're snoring, but they're still going to make some noise eventually. But if several minutes they're nice and quiet and their air is their breathing is smooth, then you're not going to have any worries about sleep apnea.
And sleep is very important. I mean, a lot of people like stress out, get anxiety. They have a multitude of different health problems because they don't get a good night's sleep. Yeah. And sleep is a huge difference. It can make a good night's sleep. So what kind of options you have? Like I have sleep apnea. So you automatically get a CPAP machine, or there are other options there?
So if you've been diagnosed with sleep apnea, there are different levels of that. There's mild, moderate, severe. And so that'll dictate a little bit about what your options are. I always encourage people, if you want to try CPAP, let's try it for 2-3 months and see how you do. Some people say, no way, I don't want that. I couldn't do that. I can't do that. Then, we'll kind of bypass that. Some insurance companies require patients to try CPAP, to do a CPAP trial for 1, 2, 3 months, so it depends on how that situation goes. But if a patient says, what are my options other than CPAP? Then what we'll do is we'll first treat the nose, because that is going to give the biggest bang for the buck, the biggest improvement. So we'll deal with any sinus stuff like Scott had, any airway blockage, whether it's polyps or whether it's a septum that's really deviated and blocking their airflow, or turbinates that are too big, or adenoids that are still present in an adult.
Which remove the whole turbinate out.
We don't take the turbinate out, we shrink it down.
How do you do that?
There's different ways to do it. There's radio frequency. There's actually cutting and removing tissue. What I like to do is, again, my passion and my approach to all these conditions is the least amount of the minimally invasive approach to get the job done and to be effective. So that's why I like the balloon, because I can clear 99 people with sinus problems up out of 100 with that minimally invasive approach. So with like airflow and nasal blockage and having big turbinates, it's very simple to shrink those down by slipping this little probe inside, little 2 millimeter probe inside. And what it does is it removes the spongy tissue that's inside the turbinate and makes the nose so stuffy. That spongy tissue really swells up when you have allergy or sinus inflammation. It swells up when you lay down to sleep at night, really blocks your nose, makes people mouth breathe, then they're more predisposed to snoring and sleep apnea. So getting that airflow at night lets people breathe through their nose, which is the natural way that air should flow into the lungs. The lungs prefer the air to come in through the nose. So what we do is we remove that spongy tissue, and that turbinate just shrinks down. We're preserving all the lining of it. We're preserving all the function of it. And there's very little side effect at all. You don't need any packing in your nose when you're done, but you've got to get those things shrunk down so they don't swell up and block up people's nose. So that's how we reduce the turbinates. So we get those airways open, deal with the sinuses so there's not sinus congestion and inflammation. And now we've gotten that patient breathing well through their nose, and then we see how they do. I mean, it's amazing how much more they improve. Let's say they're still having some snoring or they're still having some blockage. Now we move on to the second level, which is the soft palate, the uvula, that kind of thing. So what we'll do there, if patients have huge tonsils, well, yeah, you got to take those out. Now, for an adult, that's no fun.
Yeah, very painful.
Very painful. Now, what we found is unless those tonsils are literally taking up all that space back there, touching in the middle, if they're just moderate or smaller, you don't need to bother those.
I'm interested in you saying that, because back in the day, everybody's tonsil would get we were overdoing it so much. And now the consensus changed,
Changed a lot.
We want to preserve.
Taking a lot less tonsils out, which is, I am very much in favor of that approach. It carries its own risks. It's a tough recovery, every bit as tough as what Scott went through, or he could, even longer. So it's encouraging that we're able to get people cleared up without having to go to that extent of things. But what we do need to do is deal with like a soft palate that's way too long or big, too thick. And the way we're able to do that, sometimes we have to remove that uvula hanging off of there, which we can do in the office. Sometimes we just need to shrink down, just like the turbinate mucosa or the turbinate tissue inside. If we can shrink down that soft palate tissue and get it to contract and stiffen, then it's not flopping back there as you're breathing and causing all that noise. And you can do that just by introducing radio frequency into that soft palate. And what you do is you basically create an inflammatory response. The body kicks in to heal it. And this is a situation where you want to have that scarring and that contraction. You don't want that in the sinus opening, but in that soft palate you do.
Kind of helps you out, huh?
So then we address the soft palate. And then once we get that done, if the patient's still having issues, then you're dealing with a base of tongue. And with that, I like to take a very, very simple, safe approach that for a lot of patients works great. We call that an oral appliance. And I work with orthodontists here in town to just create a simple little night guard, very simple. And what it does is it can, by forming it to the teeth, you can keep the lower jaw closed, and you can keep it's positioned forward enough because the back of the tongue is actually attached to the inner lining of the jaw, the lower jaw. So you keep the lower jaw in proper position and that tongue stays with it. And all you need to move that tongue is a few millimeters and you've got a lot of more airflow back there.
That's what sleep dentistry means. I
Exactly.
guess the subspecialty, a lot of people say, what that means, sleep dentistry? I guess building those appliances for sleep apnea.
Yep, and they can be very effective.
I bet you get a lot of thank you cards from wives of people or husbands. So like, my significant other doesn't snore.
A lot of pound cake.
a lot of pound cake.
A lot of thank you cards. Yes, sir.
Snoring, I snore. My wife hates it. It just, I snore a lot. I snore more when I'm tired.
She's.
I don't know why, it's just everybody's like that, but.
When you're exhausted, you're in a deeper sleep. Your muscles are more relaxed.
But just because you snore doesn't mean you have sleep apnea.
Nope.
Because I snore a lot, and then I went through the study. They told me I don't have it.
There you go.
But then I don't really believe it because I wake up very tired also.
Well, what happens
I might come back to you again.
Yeah, what happens is that there's this in between group of people with what we call sleep disordered breathing. And it's unfortunate because insurance companies don't recognize this. When I say don't recognize, they choose not to cover sleep disorder breathing because there are patients that have enough snoring or interruption with their airflow. They don't meet the criteria for sleep apnea, but they're not sleeping well. They're probably not getting into the lower, deeper level 3 and 4 of sleep, stages of sleep. They're probably not staying there long enough. They're probably not getting in REM sleep and staying there long enough. And so because of that snoring is fracturing their sleep. And so while it's not obstructing their airflow to the degree that their airflow is stopping or their O2 sat is dropping, but it's affecting the quality of their sleep and they're waking up, they're not feeling refreshed and feeling like they had a good night's rest. And so those folks are kind of caught in the middle where, there are things we can do, but they kind of got to, foot the bill for that.
Can you even if you don't have big time sleep apnea, can you still use CPAP machine to enhance your performance?
You can use a CPAP, very simple and safe to do. A lot of patients just buy it themselves. If they're ones that are falling in that gray zone in between, they'll just buy it on their own and it works great for them.
And there are different versions of CPAP. One covers the whole face and then there's one that covers just the nose.
Yes. So we call it full face mask that covers the nose and the mouth. There are what we call the nasal mask. So it just covers the mask. And then you have what we call the nasal pillows. There are these 2 foam inserts that slide up in the nose and that's probably the most comfortable. So those are the variations. It kind of depends on what you need. If your mouth is tough to keep closed at night, you may need the full face mask. They've got some supports that you can kind of wrap around to kind of keep your jaw closed. Because if you're forcing air at a pressure, that positive airway pressure, if you're pushing air in to keep the airway propped open, if it just comes back out the mouth, you're not getting it down in the lungs. So you got to keep that jaw closed. If people, keep their mouth closed, then they have the option of this or the nasal pillow. The other thing is the pressure that someone needs. If they need a high pressure because they've got that's just what they take, then the nasal pillows may not fit. They may keep popping out. So there are certain things that dictate which one you need over another. One thing that I like to talk about with people that, are on CPAP, but they're like, I'm having trouble tolerating it because the pressure's so high. I have trouble staying asleep, or I wake up and I feel like I'm getting blasted by it, or I wake up and I pulled it off. Those folks, they typically, their airway pressures are probably over 10 centimeters, 10 centimeters of water. So those, what we do there is I said, look, if we optimize your airflow through your nose, the pressure is going to go way down and you'll have much less airflow needs, much lower pressure, and you'll be very, very able to tolerate it. And that's exactly what happens. They're like, man, that was nothing. I didn't even know I had it on once we got that done. So that's another patient that benefits from talking to us about how to improve their sleep.
Sleep is the key to a good life. So you don't need to be overweight. I have seen some skinny people have big time sleep apnea.
Big time, yeah.
So
they usually have a bit of retrognathia, so their jaw is a bit
behind.
a bit in, just retro displaced, and they sometimes need an oral appliance. I mean, some actually need the mandibular advancement surgery where they're moving their jaws forward, but those are pretty severe situations. Again, getting them breathing well through their nose is a big step. It helps them a lot. And then an oral appliance can sometimes be all they need.
Interesting. So anything other than sinuses, allergies, and sleep apnea, what else do you treat?
Ooh.
So that's pretty much all three.
Well, we do a lot of otologic or ear trouble.
Ear trouble. Okay.
The ears are they are so interconnected with the nose and sinus because of that eustachian tube. That eustachian tube opens right in the middle of all that sinus drainage. So if someone has chronic sinusitis, that inflammation, that mucus draining goes right past the opening to the eustachian tube. So the ears are affected quite a bit. So people come in, they have, popping and pressure in their ears. They get fluid in their ears. When they get a sinus, head cold, allergy flare-ups, their ears just lock down. Or they get fluid in there, and it's so aggravating, especially as an adult. We don't do well with our ears blocked up. Kids, they just kind of learn it, but adults don't do well. And I understand that. So they really are seeking relief. Even just tinnitus or ringing. If they've got eustachian tube trouble, that magnifies the noise in their ears. And by opening those eustachian tubes and optimizing the function of the eustachian tube, a lot of times that tinnitus or noise will really tone down a good bit. So people come to us for that. They come to us with those ears that get blocked. A lot come because they can't fly or dive. So we've covered that, but that's a big thing. If they have hearing loss, a lot of times it can be conductive from that. So just about any kind of ear symptoms, they're like, well, do I have wax? What do I've got going on? And we kind of sort that through with them.
Tinnitus is a big problem. I mean, tinnitus is the medical term for buzzing in your ears. It bothers people a lot, especially during the nighttime when they try to fall asleep. I got huge tinnitus problems, and you guys can resolve most of it with eustachian tube treatments.
Well, we try to be very careful to under promise and over deliver. We really what we can say is the vast majority of people that have eustachian tube dysfunction in the context of tinnitus. Some people say tinnitus, and that's a perfectly easy way to say it too. They notice an improvement. We don't guarantee that, but what we do say is the eustachian tube dysfunction you're having, that's going to get better. And if we knock out a lot of that tinnitus along the way, it'll be a home run.
Yeah, that's a bothersome, and we treat them with medication. Even chiropractors do maneuvers and stuff for tinnitus. I don't know how they do it, but they claim to treat that. It's a big problem.
And I don't know how effective that approach is. I do know we've seen a big uptake in tinnitus after COVID, both from COVID infection and the COVID vaccine. So I just had a patient in my office. So I have new onset tinnitus from the vaccine.
So vaccine causes a lot of tinnitus. Yeah. Wow, interesting.
Yep. I had a patient just today with that.
I have tinnitus. There's a case that sticks with me until today, and I never forget about it. I had a patient, 60 years old. He came with tinnitus. I mean, he was healthy, have no health problems, but this buzzing in his ear and begging me, please, like he went to ER. They did blood work. They couldn't find anything. He went to ENT. They did all the testing stuff. ENT even couldn't find anything, and multiple visits. And after that, he came to me. And I was like, what do you expect me to do? I mean, like, you've been to specialists, you've been to your primary care, you've been to ER. I mean, they did all this. And then they said, doctor, please do something. And something prompted me to do a CT, head CT. And nobody done it. which is kind of weird.
Really?
He never got a head CT. And then we did a CT of the head, and there was glioblastoma multiforme. I mean, he has a brain tumor in that side. And then I went to the patient's room. I was going to, I didn't know how to handle it. I'm going to give you, good news is I know why you have tinnitus, which is bothering you so much. Bad news is it's brain tumor. He was actually relieved. He's like, now I know exactly.
Now I know what to deal
what's causing it. Yeah. But I was surprised. I mean, it's not like they could do anything differently. I mean, you have brain tumor, but it was actually what caused it, which kind of surprised me.
Your intuition.
That was the only symptom, though. There was no other symptom, no vision changes, nothing else.
The guidelines for imaging in tinnitus is, especially if you have a unilateral tinnitus. Most folks have it kind of, they'll say, is it in one ear or both? They'll say, well, I don't know. It's just in there. Well, they probably have bilateral. But if patients, it's just right in just one ear. And that's persistent after we try a few things, then I'll get some imaging. But we'll also get an audiogram. Always we get an audiogram. And if there's nothing unusual on the audiogram, if they just have a bilateral, symmetric, typically some degree of high frequency hearing loss, it's usually someone too, where you'll see what we call a 4K notch. It's a drop at 4 kilohertz that either recovers or kind of keeps going. That's a clear indication of noise exposure. Someone was in construction, they were in the military, something where they were around a lot of loud noise and didn't have good protection. They're highly predisposed to tinnitus trouble. But we'll get an audiogram, and unless you have a real asymmetry, there's really no clear guideline for getting imaging. I mean, you just had that intuition.
I just did it because we were kind of running out of options, and something told me maybe there's something.
I think someone that's getting desperate, that's already done all that evaluation, and they're almost kind of getting desperate, depressed, those kind of things. I think that's a wise thing to do, to go ahead and just get something, because it may give them some peace of mind to know, all right, at least they checked. I don't have a brain tumor.
Do you have an audiologist in your office?
We do not. We team up with some local audiologists, a couple different directions on Sunset, where they can get them in quick in just a day or so.
Yep. That's hearing loss is a big thing too.
Oh yeah.
And why those hearing devices are so expensive? It's a couple $1,000. I'm just ridiculously.
It's just like the new phones that their technology is advancing so rapidly. And, especially the background noise filters, because that's the real bugaboo, is people being able to use them in a crowded restaurant to be able to talk to each other at the table, but that ambient noise can give feedback, and that's what that technology is really working on. And so it's expensive to develop that, and some of those components are expensive. And so, the new phones cost a lot. The old ones just drop, like TV, same deal. It's just that more technology, but over time it kind of drops. And so, some very good hearing aids now have kind of dropped into more reasonable levels, but the most sophisticated, newer ones, they are thousands of dollars.
I mean, there are two items. They're very sought after in nursing homes. They're the most stolen items from people's homes. People's rooms in nursing homes. And number one was the hearing device. And number two was dentures. But I don't know what I think about that.
I don't get that one.
Number two was the dentures. And I was like, what you doing? Wow. What you guys are doing? Nursing homes are interesting places. Number one for theft and number one for STD. So we don't know. That's weird places. But
yeah, not a place you want to.
I think it's a good place to be a man, because your ratio of man to woman is 1 to 4 or something like that,
Yeah, man.
You're definitely a minority if you're a man in nursing homes, so that's not be a good thing. Well, thanks for coming here. It was a pleasure to talk to you.
I've enjoyed it.
I think our audience will appreciate knowing all these things, learning about it. And these are very commonly debated, commonly asked questions. So I'm glad you answered a lot of our questions about these issues. Thanks for coming
having
here.
Me on. You have a Great podcast, great show, and gives a lot of information to your patients. I know they appreciate it.
Thanks for educating
Thanks,
us.
Dr. Hartman.
Thank you.